Thank you very much. Can you hear me at the back? That's grand. Thank you very much. And it's actually an honor to be here today. This is actually the second time I've been in this part of the world, and have grown to love it very much, but quite terrified driving here because the laneways are just nerve-wracking. So I'll end up going back to Belfast as a broken man. I'm a little humbled as I stand behind the podium today because there were two excellent speakers who preceded me. And not only your presentations were excellent, but the subject matter was quite moving as well. And to me, really spoke to the significance of holistic care. And some of the key words that I heard was the importance of art, the importance of touch, and something else which you touched on, but is this notion of trauma. And it sort of triggered something from personal experience of a loved one, and perhaps during this presentation it will weave itself into the story which I'm going to share with you. In terms of my own personal story, what you heard as I sit as a professor of palliative care in the School of Nursing and Midwifery at Queen's University, Belfast. But I'm not a clinician. I'm a social scientist by training. I work with clinicians, medics, and health social care professionals. But also in recent years, the closeness of dementia has become more of a lived experience in terms of witnessing it with close immediate family members. So, for years it was an academic exercise. In more recent years, it's become a very close experience, which is actually, has been a thankful experience for that matter in terms of really strengthening one's energy in the field, or vocation, if you will, and also sort of highlights the importance of the work that we all do and the commitment what we do in this field. As an academic, in terms of professor of palliative care, a lot of my work is around what's described as health services, health systems research. And in that, it's the idea of identifying need, recognizing the lived experience, and translating that into the development of social service models or integrated systems of care. And so a lot of my work will be sort of putting together demonstration projects, evaluating existing projects, assessing their merit with respect to efficiency, effectiveness, and equity, and then generating recommendations either at the practice or actually at the front line level by the bedside, administrative, or in the policy. And I think it's that last bit in terms of trying to translate evidence into practice, which probably is sort of the existential crisis that people in my profession experience, because it's the difficulty of trying to promote evidence-based or evidence-informed practice within trying to promote it full stop. But that's the work that we have to do. In today's presentation, what I'm going to be talking about is this notion of an integrated life course approach to palliative dementia care. I think I have approximately 45 minutes thereabouts. I've gone through my notes, they're right in front of me. I'll be flipping through pages, and I'll wax and wane for a bit. But we do, in prepping for this particular this session, in consultation with Paul, we felt it would be a good exercise to engage with you in terms of what works, what doesn't work with respect to the delivery of care for the people that we're concerned about today. So it's not all me talking, there's going to be some onus on you as well. Now, how do we do this? Okay, so there I am, and here I am, and let's see what this says. Okay, so these are the main, here we are. Okay, I'm oriented. So these are the main messages which I'm going to share with you today in terms of why, and a lot of the work which I do is around advanced care planning, or what is now sort of more broadly described as future care planning. It's around sort of communication, shared decision-making around goals of care at the end of life. In my case, over the last few years, has been the focus around dementia care. And that usually engages family members or significant others. So that will be weaved in this story, this presentation today. And so why future care planning matters. And then why prognosis is uncertain but still recognizable. And how to communicate well about advanced care planning. I think I've got that in this slide deck. I hope I get it through. And also, what does good care look like at the person, service, and system level. So that's sort of the key messages which we're going to roll through in today's presentation or talk. But I guess the main thing, where do we start from, is this notion of palliative care. Classic definition, as you can see, it was developed by the World Health Organization in 2002. And it's pretty firm, has stayed the same, but it's really important to start off from that point of view to remind ourselves what exactly are we talking about, or if we're sort of as a scientist, how do we operationally define the terms which we're using so it's mutually understood and shared. So you can see in this particular definition, which maybe some of you, if not all of you, recognize, it does speak to this notion of a holistic approach to the person, or whole person care. And you can see that there is in there a life course perspective around the care of the individual or the application of palliative care. One of the things to note around this notion of palliative care, it represents both a specialty, where you have individuals trained as and practice as, but it's also recognized as an approach, a palliative care approach. So that's something to note, and sometimes can be confusing when we get into conversations around palliative care. What is palliative care? But one of the critiques of palliative care is that historically, and you can actually argue to this point as well, is that it has been largely cancer-focused and has sort of marginalized or forgotten those individuals who are living with life-limiting progressive conditions, dementia being one of them. That's changing, and we'll be exploring that a little further on, but it's one of the critiques that's been leveled at the palliative care, I guess, practice, and there you have it. So what's important here is that, historically, dementia has not been recognized as a terminal condition, and which has led to poor access of care and inconsistent quality of care. This can be quite problematic, especially in terms of my own experience talking to families where it's not recognized by family members, so it's hard to engage in those particular conversations around goals of care at the end of life. They don't see dementia as a terminal condition, and they shut down the opportunity to have those conversations around what matters as the individual approaches the end of life. So the ability of health and care professionals to recognize when someone is entering that last year of life, and the ability to be able to discuss end of life openly, honestly, and sensitively is the essential gateway to appropriate end of life care. So this here, for me, I think was a turning point around this notion of dementia palliative care. It was published in 2014 by a colleague of mine by the name of Jenny Vandersteen, who's located in the Netherlands. And she sort of led a task force with embedded within the European Association of Palliative Care. And it was really trying to articulate what is dementia palliative care, or palliative dementia care? What does it look like in practice, and how does it differ from traditional or conventional palliative care? Unlike general palliative care, dementia palliative care emphasizes comfort and dignity over a long, gradual decline. While both approaches aim to alleviate pain and symptoms and offer psychosocial support and assist families, dementia palliative care is adapted to the unique decline of the person. And in my opinion, this particular paper, which came out in 2014, really was certainly from the catalyst, I believe, in terms of sort of triggering those conversations and using those expressions around dementia palliative care. So it's relatively recent. I think it's around, 10, 11 years, if this came out in 2014. But it's gaining a lot of traction. It's becoming more widely recognized. So one of the things about that particular paper that Jenny sort of produced is that it actually generated something to the effect of 57 recommendations related to the provision of dementia palliative care. And in this particular slide here, I've sort of chosen some of the areas which I think represents, from that document, which represents optimal dementia palliative care. Recognition of dementia as a life-limiting illness, which is key, both for providers and also for family members or people, cousins and so on. the importance of advanced care planning, or now how we're reframing it seems to be like Mary Curie is now using the language of future care planning. The importance of symptom management. And there has been some discussion, how does a palliative care approach differ from a person-centered approach? I think it's a moot point, but those people who say there is a difference will argue that a palliative care approach does promote this notion of symptom management with respect to the care of the individual. I don't know if I buy that. I think a person-centered approach does cover that as well, but it's kind of a point that's sort of thrown around in these communities. Also, the importance of multidisciplinary support. We know this, we recognize this. I'm sort of preaching to the converted here. The importance of caregiver education and support. So the idea here is that, and I think it's caregiver here is not only those the formal care providers who provide care, but also family members who provide care as well, and the importance of education for both parties. And a lot of the work which I do is around training and education for both parties, so they come together at an equal playing field and can have meaningful and understandable conversations around what are the goals of care at the end of what does the end of life look like for somebody living with dementia, and what represents good comfort care at the end of life. Also, this idea of focus on the quality of life, especially towards the end of life, anticipatory guidance for the end of life, and that goals are dynamic and prioritized as dementia progresses, shifting towards more comfort and dignity rather than life prolongation. So these are some of the key points that came out of that particular document. So we know that prognosis is unpredictable, and one of the hardest things about dementia is that the prognosis is uncertain. People may decline slowly over many months or many years, but they can also worsen quickly with an infection, a fall, another illness. People may live for months or years after severe decline begins. It is difficult to know how long someone will live, and that uncertainty makes planning harder but more necessary. Prognostic uncertainty does not mean no planning. The key message is to prepare for change rather than to predict exact timing. Some authorities, such as NICE, will suggest that people living with dementia should be offered palliative care from diagnosis because progression is unpredictable. Some of you, if not all of you, will recognize this particular framework. The NHS Transformation Framework, Well Pathway for Dementia. This is a lifespan continuation, it's sort of a life journey for the person living with dementia. It was introduced in 2016 as a strategic transformation framework. It built upon the foundation of the 2009 Living Well with Dementia, which was a national strategy and subsequent Prime Minister's Challenge on Dementia in 2020. So those are the policy documents which have been rolling out and have been trying to inform us and trying to address the issues. The pathway is intended to guide local dementia strategies and assess service quality with the goal of ensuring that care is proactive and supportive. So that's kind of the policy speak associated, which revolves around this particular framework. We do know that there's some positive aspects to it in terms of minimizing the risk of dementia, awareness, promoting awareness on the front end, and so on. And the reception overall has been positive. However, there has been criticisms with respect to this framework, as with any particular framework, that being inconsistency of care. It's really translating the aspirational to practice and the gap that can transpire between the two. Stakeholders like the Alzheimer's Society have noted that while the vision is strong, people living with dementia often do not consistently receive the high-quality integrated care the pathway promises. And we've all lived that as providers, and probably if people who have loved ones living with dementia. And the integration challenges. Some reviewers highlight that care remains fragmented in many areas, with a reactive rather than a proactive approach still being common in acute care hospital settings. So, and there's of course concerns over waiting times. So we have an aspirational document which serves as a roadmap that facilitates discussion and initiatives within communities, etc. But also we recognize some of the challenges embedded or behind that particular framework as well. Now, one of the things when I was, actually, to be quite frank, I didn't see this, I wasn't aware of this. I mean, this may be a function of sort of living in Ireland, Northern Ireland, and not being fully tied into the English situation, what's happening here. So I wasn't aware of this framework until I had conversations with Paul in preparation for this event. And he shared with me this framework. And I said, yeah, that's an interesting framework, but a little unsettling. And I couldn't put my finger on why. For me, it was unsettling, other than what I shared with you that others have said. And I'm going to share with you another slide. And this slide here is really, you can say, it's closer to what perhaps the lived experience is around dementia progression and the suggestion of prioritization of care goals. Okay, let me just take a look at my notes here so I'm not lost. If I'm lost, you're lost, so this is really important. It represents, this slide here that was in Jenny's piece, represents a model of changing care goals and priorities throughout the course of the lifespan of a person living with dementia. It suggests a prioritizing of care goals that may apply at the same time but have variable relevance to different stages of dementia. And that's why I like about this particular sort of, some of you have probably seen slides like this or sort of pictures like this. It's not new. It's been around for about 2014 in that paper. But I think the problem with the slide we saw prior to it, it kind of brackets and segments what the lived experience it is. It's not that neatly compartmentalized and can be problematic if you accept that type of a graphic at face value. This here, what I like about it, as you can see, it talks about if you look at maximization of comfort, which when we're talking about end-of-life care and comfort care, you do start earlier in the process and becomes more important with respect to as the person nears the end of life. What's also nice about this is the notion of bereavement or sort of aftercare. And for family members who have a loved one living with dementia, there's two types of bereavement. There's anticipatory grief, where you've lost the person you know, and then of course there's the pattern when that person actually dies. There's two types of grief that people will experience. So and it's interesting too. Sometimes that sort of it's in many occasions from my experience, it's that sort of second time the grief on that second time around can actually be a relief. I've witnessed that with a number of family members. Where individuals promptly go off on a cruise, and it's almost celebratory with respect to what transpires. Not everyone, but so there's a variation of individual reactions in terms of what grief can look like and how it's expressed in that second phase. As with any model, the visualization of care goals represents an abstraction of reality, and in practice needs to be tailored to the needs and preferences of patients and families. So I just shared with you two particular slides, and this one resonates more strongly with me because I think it's closer to the lived experience and journey. I was just looking at a recent publication from colleagues, 2000, what year are we in, 25, 26? We're in 26, but this came out in 25, and they've tweaked it a bit, but it's the same, although they've tweaked it slightly different in appearance, it's held on to that notion that it's simultaneous, there's multiple things happening at the same time. So I like this approach, and I wish that the prior slide was more dynamic and recognized that. You could argue that a person-centered approach would sort of acknowledge that, but we have to be careful how abstraction can really shape behavior, practice, and our individual perspectives. Okay, how are we doing? Doing okay? I was quite intimidated coming up here because I was so impressed by you guys. So anyway, when we're looking at the lifespan of dementia, and as we near the end of life, what we have here, there's two pieces to the slide. There's earlier I highlighted that dementia rarely follows a neat timeline. And however, there are signs that someone may be entering the final stage of dementia. These include, as you can see here, on the late stage dementia, more frailty and falls, more infections, eating, drinking, and swallowing problems, less mobility, more sleep, less speech. When several of these changes are presented together, it should prompt a review of care, a conversation about goals, and consideration of comfort-focused planning. Now, as someone gets closer to death, further changes may occur. These may include, as you can see, the signs of dying. This could be loss of consciousness, unable to swallow, agitation or restlessness, irregular breathing, rapid breathing, cold hands and feet. These signs are often mean that the person is within days or hours of dying, and the priority becomes comfort, symptom relief, and helping the family understand what is happening. Especially, certainly from what I've heard from the rattly breathing, this can be quite distressing for family members. They don't understand what it is and can trigger a lot of anxiety and concern. So it's really important that the providers, a lot of my time is spent in nursing homes, so it's really important that in that instant, and usually individuals in the advanced stages of dementia are found in nursing homes. It's quite exceptional, very rare from my experience. But it does happen. I have seen it happen where the individual living with dementia will die at home. But to enable that to happen, I know of multiple sisters who have rotors. It's a real hands-on sort of process. But the family's fully committed to making that happen. But more often than not, the individual living with advanced dementia and who's actively dying is actually in a care home or nursing home, from my experience. And it becomes extraordinarily important that the care home staff are cognizant of what death looks like and also have the ability to communicate and share that, communicate effectively with family members around what to expect and also what it means. And that's actually what a lot of my work does in terms of educating care home staff, in terms of communication with family members. So advanced care planning, and this is actually an area which I've been hanging my hat for a number of years in terms of, what is advanced care planning? How do you actualize it in practice? What does it look like in practice? What are the benefits of it? And in my own practice is sort of educating staff and family members around this notion of advanced care planning, creating tools, educational packages, evaluating the impacts. And typically, as we're talking about advanced dementia, typically this takes my experience into the care home settings more often than not. Okay, I've lost the order of my slides and this, but we'll see where we take us. So the planning is not about giving up. It is about preserving personhood and avoiding crisis decisions later. Advanced care planning helps ensure wishes are known and respected. It is linked to quality of life, autonomy, and reducing distress for families. So that's aspirational. That's what we want those conversations to kind of convey. That's the type of impact we want them to have. And advanced care planning, you can see here's the definition. So that once again, it's this idea, speaking as a sort of a researcher, a scientist, we need to define our terms so that we have a common understanding about what we're talking about. So what we have here is a definition of advanced care planning, but also specifying what it includes. And as you see in the slide, what it matters most to you, where you would like to be cared for, what treatments you would or not want, who you want to speak for you if you cannot make decisions. So that's really interesting because when we're talking about dementia, it's usually the family members who are making these conversations. Now, it's actually a really interesting case which happened in Canada. And in Canada, assisted dying has been legalized. It's under debate. Actually, it's been canned, actually, hasn't it, but, in England. But in Canada, it's been legalized for a number of years. But there was a precedent-setting case in Canada about 3 years ago where where an individual was diagnosed with dementia, and with his loved one indicated that he wanted to elect MAID as an option when he was at a certain point in his trajectory. And he continued on the trajectory of dementia, the progression of dementia. But what transpired is that his partner was an active agent in terms of pushing through that he carried out that his wishes for MAID, assisted dying, was respected and enacted upon. And that happened about 3 years, and it happened. And that happened about 3 years ago in Canada, was precedent setting. Now, it just turned out I was in a conversation with a friend about a month ago in Canada. I was back there in March, and somebody I knew was just diagnosed with dementia. And he has elected for MAID. And he's in early stages of dementia. And they've sold their house. His wife is moving to a different location. So his advanced care planning was pursuing MAID at the early stages of dementia. So now the debate with assisted dying in Canada is decide where does dementia sit in in advanced care planning and the realization. But those are two examples. 3 years ago, where it made the headlines, somebody living with dementia put it in their sort of advanced care plan, but the insistence of their loved one to push it through to make it happen, to just a month ago, about 3 years, where somebody was diagnosed, has elected for MAID, and is going to proceed with it, and the families reconcile themselves to it. So that's a feature in another context around what can be embedded within an advanced care plan. Not in this context, but in another jurisdiction. Controversial, very emotional, highly individual, but we'll see what happens here in the UK. So that's a definition of advanced care planning. So why is advanced care planning essential? And why should you be triggering it sooner than later? And this slide here not only highlights why it is important, but also highlights the challenges that families face as carers, and how ACP, or advanced care planning, assists and supports families. Usually I have my notes and I promptly forget about them. I just wax and wane, but I'm trying to stay on target. So why is advanced care planning? We recognize that cognitive decline reduces the ability to plan later. Communication becomes harder over time. Capacity is lost. We know this. We all know this. And it reduces unwanted interventions. That's why advanced care planning is so important for those living with dementia. Why is it important for family members? And I've seen this with families from the work I do. There's uncertainty about it, the weight of responsibility on family members who are trying to second guess what their loved one would have wanted at this point in time in this situation is incredible. And so there's uncertainty about what the person would want. There's emotional burden of being a surrogate decision maker. There's actually the practical strains in terms of managing and coordinating care. And there's it's the measure of guilt or burden that family members have and the fear of making the wrong decisions. Embedded behind this too, which I didn't put down, is also the divisiveness that can transpire within a family unit in terms of siblings and brothers and sisters and cousins about what the right decision is. So that's why advanced care planning is important to insert into the process as early as possible, or somewhere along. The received wisdom is that the sooner we have these conversations, the better it is. I'm not quite sure about that. I think that it really speaks to this idea, like we saw the NHS framework. It's this idea that what's really important is that. When people, like today, somebody could be very resistant about having those conversations. Tomorrow, they may be very keen to have those conversations for whatever reason. Usually it's a catalyst, it's a trigger for that. But what's important here is generating awareness that this is an option, and then having a vehicle so that the providers or their loved ones or whoever those individuals are, I guess, switched on or mindful that timing is everything, and where a person sits today may be different from a month from now for whatever reasons. So the issue with respect to the received wisdom is that these discussions should be happening at the point of diagnosis. I've sat in with psychogeriatricians when bad news has been broken in, and families are shell-shocked. They're harboring it. They don't want to admit it, but it's like sitting on the other side of the table and witnessing the impact of this diagnosis. That's not necessarily the time, and what they say, the issues there are more functional, driving day-to-day living. So the received wisdom from some is that those conversations, the earlier the better. But it's, again, what we're talking about is a person-centered approach in terms of the timing and recognizing that there are individual differences. So I think I just got off track, but I thought, an important point. So key components of the ACP discussion. I had timing here. What we have here is that there's a statement of wishes and preferences for future care should consider the following. Psychological support, for example, well-being support, particularly with worries and distress. Social support, for example, including appropriate support contact with families, friends, individuals, spiritual support, etc. I'm going to just skip through this. A lot of you may know this already in terms of what should be included in the advanced care plan. But there can be variation across regional authorities. There can be variation across regional authorities in terms of how it's documented. There can be variation across regional authorities in terms of training made available to healthcare providers to have these types of conversations. There can be variation at the individual level in terms of the competency and confidence of healthcare providers or social to have these conversations. So once again, I think what we're looking at, these are the key components of an ACP discussion. But once again, we're sort of somewhat aspirational. I remember on one occasion when my mother was admitted to a nursing home, and as part of the admission process, I sat down with the nurse, and the entire admission process was maybe 15 minutes. And then I shook my head afterwards, said, oh my gosh, she was having an advanced care planning discussion with me, and I had no idea until after the fact, It was just glossed over. So God knows what the record looked like that she transcribed. So there's this idea, we have a gold standard of what should transpire in this conversation as these key components reveal. But how that is transpired in the transaction between the provider and the listener, or in this case myself, can vary. And we're going to get back to that a little further on, and I'm going to share with you some of the work we've done trying to sort of ensure a more consistent approach in terms of how healthcare providers have these conversations. How are we doing for time? I've lost track of my time too. So.
You're due to finish at 1:15, but I think you wanted to leave some time for something else.
We're going to do an exercise. I have 10 minutes for my presentation. Perfect. Okay. Thank you. Okay. So here we have it. Features of ACP at diagnosis, but those who advocate at diagnosis, they say not all at once. We don't want to dump it on the individual. But it's really this idea of after the person has processed the diagnosis, or as I was talking about earlier on, when a change in health or function occurs, after a crisis, et cetera, and so forth. I'm not going to go into detail this because I'm preaching to the converted. I think you know this. I hope you do know this. If you don't know it, I have a website for you, and we'll go through it later on. But there are misconceptions about ACP, that ACP cannot be changed, and that's not true. ACP is an ongoing process. ACP can be reviewed and updated, especially if wishes change or if healthcare plans change. The ACP should be made when someone becomes unwell or at the end of stage. Not true. Right now, we're taking a public health approach around advanced care planning. Everybody should be aware about this. I have colleagues who say that this should be introduced at sort of sort of at the teenage years as well. We should be having a public conversation around this. So anyone can make a plan. Early ACP suggests disease progression or poor prognosis. Not necessarily. It's like you should treat it as equivalent to doing your will. ACP is only about treatment or CPR. Not necessarily. It's part of, but as you heard earlier on, wishes and preferences is part of that. ACP is the role of the GP or specialist. That's an interesting point. It's, if you look at the literature, say somebody who has a trusted relationship. I'll share with you a slide that we did some work with GPs in terms, GPs feel that they should be involved in this type of conversations. I think what's the average encounter a person has with a GP? 5 minutes? Less than? 2 minutes? Nil, if you can't get an appointment. So I'm sort of defaulting now that it becomes the role of the district nurse. So we've done a lot of work in terms of developing sort of looking at the roles of nurses in terms of having these types of conversations. We've developed resources in terms of training nurses, district nurses, and family members. So that's where we're looking in terms of, so yes, anybody can have these conversations. The literature say a trusted relationship. Having said that, I think it's district nurse may have the space, capacity, and more of a trusted relationship from my perspective. Okay, this here, I think I have like 5 minutes left. We did a study in Northern Ireland. I was sort of, we published in Dementia 2000, thereabouts, 15. And we wanted to know what were some of the barriers with respect to providing quality dementia care. And I'll just quickly go over this. This was pre-COVID, and I was actually sitting on the fence whether I should share this with you. A, is it too old? B, it's from Northern Ireland, so does it generalize to Cornwall? I think probably I'll let you be the judge of that. I suspect it does. I don't think it's too old. Probably the issues will resonate with you. So these are some of the perceived barriers to dementia, the provision of dementia palliative care. Lack of knowledge. I'll skim over it quickly in the interest of time. Limited availability of resources, we all can identify with that. Mismanagement of appropriate care, poor interdisciplinary, and also the need to support families. This is what the GPs identified as practice issues that sort of are service barriers of. But they also did sort of highlight what the workarounds can be. And in terms of, the timing of, should be determined by the readiness of the patient family, which I signaled earlier on, the importance of education and training, and that was actually really, and of course, additional resources into the system. So I could go on for ages about this, but I'm just giving you a quick thumbnail stretch. This will be important in the exercise we're going to do in a moment. I'm going to quicken along. What's going on here? Okay. So, improving the provision of care. What I'm presenting to you, this is going to be your assignment in a few minutes. So this is a framework for improving care from a micro, meso, macro perspective. It separates action at the bedside, the organizational level, the system level, and this sort of helps align person-centered care service coordination policies, which changes at one level to support the other. So this is a whole systems approach in terms of improving dementia care, dementia palliative care. So that's what I'm promoting here. Micro level, direct care with the person with dementia. This is day-to-day shared decision-making. In the care home environment, it really is, there's a three-legged stool. That would be the resident, the care worker, and also the family members. Those are the optimal, that really works. And as a personal example, I remember a gentleman who was newly admitted to a nursing home. He had this disruptive habit from the staff perspective of getting up around dawn and wandering around the hallways. And then on talking to the family members, they discovered he used to be a milkman. So what they did is they got a little basket of bottles, and this individual would get up at dawn. He would deliver the bottles outside each door, and he would go back to bed. So that's an example of, the three-legged stool working, I can give you a personal example of my mother who turned 100, and we got a call from the care home. She was struggling to get out of her bed. She was talking about the fires and how we had to rescue people from the fires. Well, she had lived through the Blitz, and so this was going back to this notion of trauma. The care home staff called us up. They didn't know what was going on. They were panicking. It would have triggered a reactive piece, but we knew her story, and we were able to share with them that it was post-traumatic. And that's what we're hearing more now in terms of people living with living with dementia and the role and issue of trauma. And some of you may have witnessed that already, but we're seeing more of it. Certainly, I think there's something on BBC now about people who lived through the Blitz, children who lived through the Blitz, which I haven't seen yet, but it's on my list. So examples of best practice at the micro level. These are some of the examples which we'll be looking at. Meso. I'm going to flip through this in the interest of time. You're going to give me a warning. Unless my presentation is so riveting, we'll just throw away the time. We'll just keep macro level. One of the things that we have done is, which works at we developed what's called the decision support, family care decision support intervention. And this is at the meso level, or meso level. And the intervention we developed, applied to nursing homes, involved training nursing home staff, in terms of having these advanced care conversations, training them in terms of organizing a family care conference, all surrounding what we're calling the Comfort Care Booklet. This is the Comfort Care Booklet. It has the following sections involved in it. We've just revised this, so we have the 2026 edition, so it's kind of in current best practices. And it's a tool. It's actually a good educational tool for staff. And it's the idea is to educate family members around these comfort care options. And embedded in it, we developed what's called the question prompt list. So these are the type of questions, sometimes families will come up cold in terms of what type of questions do I ask at the family care conferences. So we get, these are like aid memoirs. These are sort of ways of triggering questions that family members would have. So I have 1 minute, and I have 15 more minutes to go. So there is evidence behind this. We evaluated it at a national level, or in Northern Ireland, I should say, a clustered randomized controlled trial of 24 homes. It was effective in terms of reducing decision uncertainty and perception of quality of care in the nursing home. We scaled it up at a transnational level and implemented in 6 or 7 countries there, funded by the EU and the Alzheimer's Society here in the UK. And those findings continue to be robust. We've just received funding from Horizon, where we've yoked that intervention, the family care decision support intervention, with Namaste. You're familiar with Namaste? So it's like real-time care and future care planning yoked together. And we're just rolling that out across 56 nursing homes in 6 countries. That's a lot of work. And this, the biggest vehicle in terms of getting this out is we've digitized it. And so you've got this is the intervention online. And we're promoting this, and reflective practice. And you can actually download the booklet. We're just sort of in discussions with our communications people to upgrade this. How are we doing? Okay, great. I'm done. And this goes to you guys, which is a reflective question. On your tables, you have paper and pens. I'm sorry, I thought during break we could do massage, and we can disperse with this, but I didn't think it was going to work. So we're not going to be doing massage. We're going to do a sort of a classic paper and pen. So the question we're putting to you is, if we know what to do, why don't we do it? Okay?